third webinar in the last 2 days. And we had a tremendous response yesterday from the nurses and all the frontline health workers. We had a lot of interaction about the queries that they had regarding stroke and prevention of stroke, and also about control of hypertension. And today we are addressing the physicians who are at PHCs and CSCs level, and also district hospitals. And we are going to talk about importance of stroke recognition and how early you need to identify these patients and provide them and guide them for the appropriate therapy. And at the end, we'll be very happy to take all the questions that will come from your side. And with that, I'll hand over this session to Dr. Arvind.
Thank you, Dr. Jaraj. Very rightly said for yesterday. It was a wonderful session with the nurses and the healthcare workers, and the attendance was tremendous. So I will ask now Dr. Prabdeep to have some introductory words.
Thank you, Dr. Arvind. It's a pleasure to be part of this webinar, and on behalf of India Hypertension Control Initiative, I would like to welcome all the participants who have logged in, and I can see people are just logging in, number is increasing. So as you all know, India Hypertension Initiative, I'm sure many of you have been formally trained or have been part of our various capacity building initiatives. We are trying to work with the state health systems, district level health system, and doctors and nurses to improve management of blood pressure in 100+ districts in India. And doctors and nurses are really the front line, and they are doing tremendous job, and we have seen a lot of progress in the last 3 to 4 years. And as we all know, one of the important reasons why we want to reduce blood pressure is because we want to prevent stroke and heart attacks. And to do so, we need to make sure that we have systems in place in terms of trained workforce, drugs, information system, and all of that. And we have been trying to work on those kind of strategies with all of you. So today's webinar will focus a lot on identification of stroke at the early stage, and then what you could do to manage. I'm sure you will have a lot of questions in the end. Yesterday we had a lot of questions from nurses as well. And we'll be briefly also talking about how to prevent. And we feel, as we discussed yesterday, half of the work is done if we can control blood pressure. So we really have this very, big role to play at the primary care level. So really look forward to interacting with you all, and hope you will find this interaction fruitful. Over to Dr. Arvind.
Thank you, Dr. Prabdeep. And very rightly said about the collaboration with the India Hypertensive Control Initiative and ICMR. And talking about ICMR, we have Dr. Meenakshi Sharma, who is a very senior scientist and ICMR heading for the non-communicable disease. I would like her to, and as she told yesterday, we like to have more and more collaboration like this, and we found it very fruitful on all aspects to say some introductory words. Dr. Meenakshi Sharma. You are on mute, Dr. Meenakshi.
Yeah. Good afternoon, everyone. Am I audible?
Yes.
Can you hear me?
Yes, you are audible, Dr. Meenakshi.
Thanks a lot. I think this is a very good collaboration which has been initiated by Indian Stroke Association, ICMR, and the first of its kind between the public and the private sector. And we are hopeful that this will go a long way in prevention and control of both hypertension and stroke. So as far as hypertension is concerned, we understand that only 10% of our hypertension, in only 10% of our hypertensive patients, the blood pressure is within the control range. Not only that if we target only the public sector, then we realize that large number of patients are being treated in the private sector. So both sectors are equally important, because the public sector caters to a class of population which may not be able to afford the costly treatment within the private sector. So both sectors are important, and both sectors have to work together in order to control both hypertension as well as stroke. So ICMR has launched India Hypertension Control Initiative with an objective to increase hypertension control rates from 10% to 30%. And definitely, as I said earlier, this can only be done through public-private partnership. So our PHCs are going to be very important because they are near to the home of the patient. And if we are able to control hypertension, then I think then the numbers of stroke are also going to go down. In our country, there are around 7 lakh stroke deaths every year, which is a large number. They represent around 7.4% of the total deaths in the country. So it's a large number of deaths, but the disabilities are even much more. And these disabilities affect our homes, affect our families, our society at large, and the country's economy, because 25% of our patients are below the age group of 50 years. So you can understand the immense importance of preventing stroke. And for the stroke, there may be a number of risk factors which are common to all NCDs. But if we have to single out one risk factor, it is hypertension, hypertension, and hypertension alone. If we are able to control hypertension, then we will be able to control our stroke, prevent our strokes also. So ICMR undertook population-based registries, and we realized that a stroke is not prevalent only in the cities, in the urban areas, but is there at a much higher level in rural areas too. We took help of the ASHA workers in screening stroke patients, and we were quite successful with that model. The task shifting process, this was quite remarkable in a way. The ASHA workers, they were able to identify stroke patients with the sensitivity and specificity of more than 90%. So that model which we tried in Ludhiana, rural Ludhiana, we are trying to see whether this can work in remote areas of Northeast, including Dibrugarh and Tezpur. But our experiences in rural stroke registries in Ludhiana as well as in Bangalore, they told us that our patients are not only not going to PHCs, but going to traditional healers. But the issue was that the ASHA workers, they wanted to do something more than counting the numbers of the stroke patients. And they were the ones who told us that the pathways for stroke care, they are not available in the rural areas, in our PHCs and CSCs. They said, what is the point in collecting numbers if we are not able to give care to them? And any research without service, that doesn't have much of value. So realizing that we are trying to build up stroke care models in remote areas of the Northeast, we have taken in 2 places, one in Dibrugarh and one in Tezpur, where we have a public-private partnership hospital and Tezpur Medical College participating in that. In Dibrugarh, we have got Assam Medical College, but the conditions are very different in the 2 medical colleges. In one medical college, in Assam Medical College, we have at least 1 neurologist over there, and MDDM students, they are also there. In neurology, they are also there. But in Tezpur Medical College, if we look at that college, then we don't have any neurologist over there. So the work was a little harder there, because we realized that if we have to treat stroke, we cannot be dependent only on the neurologists. So we required to build up stroke units in these medical colleges, which we have done in both Tezpur Medical College as well as in Assam Medical College. But we trained our physicians over there so that they are able not only to diagnose stroke patients, but they're able to give treatment, manage the stroke patients too. So we provided them all the facilities for a stroke unit. We had Baptist Christian Hospital with us, which was a little more trained as compared to Tejpur Medical College, and gave assistance to Tejpur Medical College in that fashion. And we built up a pathway for telemedicine consultation with CMC Ludhiana and All India Institute of Medical Sciences, Delhi. So once that was cleared, we thought that we require to bring CT imaging close to the patient's door, because that's the thing which demarcates between the two types of stroke, ischemic stroke, because there are physicians in the stroke. So I'm not going into the details of ischemic stroke and hemorrhagic stroke. So, but you have to diagnose whether it's a ischemic stroke or a hemorrhagic stroke, for which CT scan facility is required. And as we all know that CT scans, they may be available in the urban areas, but they are rare things to see in the rural areas. We set up 2 mobile stroke units, which are a big ambulances actually, loaded with a CT scanner, along with a laboratory facility, telemedicine facility, and a facility to start the thrombolysis therapy there in itself in the van. So one at Tejpur and the one at Dibrugarh. Dibrugarh was initiated in this March only, and we are trying to conduct dry runs over there. In Tejpur, we have conducted dry runs there. Because of COVID, there were some issues in initially launching these vehicles, but now we have got at least 4 patients, out of which 2 were stroke limits, but other 2, they were hemorrhagic stroke patients, and they were managed over there and then sent to the stroke unit, which was set up in Tejpur Medical College. Now, interestingly, we also realized the importance of stroke unit in this project. We realized that the patients, there were 2 patients I remember which came a month back to Tejpur Medical College. Both the patients, one male, one female. They were below 30 years of age, and I do agree that this is not a magic bullet, but for these 2 patients, it's worked like a magic bullet. And within half an hour, we were able to, from door to needle time was half an hour. You know, the golden period for stroke is around 4.5 hours. And once a patient reaches the hospital, then it has to be done very quickly. So both the CT scan, the thrombolytic therapy was initiated within half an hour. And there we go, both the stroke patients recovered easily. Even within the hospital, in hospital, they showed massive improvements. So yes, stroke is treatable, but every stroke patient will not have that kind of improvement. But if they reach within a window period, there's a chance that the lives will be saved and disabilities will be less. But then it's very important to understand that if we want to prevent stroke, we have to talk about hypertension, which we are doing through India Hypertension Control Initiative program. Your PHCs, they are very important for us. The PHCs help in identifying the hypertensive patients. And if you are able to identify the stroke patients also, then I think the PHCs can provide a referral to higher facilities so that the stroke patient gets a cure within the golden period of time. And back referrals, if they can be done from the district hospital to the PHC, then I think the stroke rehabilitation is also possible through your help. So with these words, I think the importance of PHCs, the importance of ASHA workers, the nurses over there, the physicians over there, this is tremendous. And we are hoping that through these webinars, we will be pulling you into the lifeline of stroke management. Thank you very much. Thank you, Dr. Arvind. Thank you, Dr. Pradeep.
Thank you, Dr. Meenakshi Sharma, for a wonderful brief and introduction about the stroke management. And thank you, ICMR and the India Hypertensive Control Initiative, which is definitely very important for us to do the across India to manage the hypertension. So now moving forward with the program. So we welcome our executive member from Indian Stroke Association, Dr. P. Vijaya to talk about the stroke prevention and management, and followed by that, Dr. Ganesh will talk about his talk. So Dr. Vijaya, the dais is yours.
Thank you. Thank you, Doctor.
Yeah. We can see your slides. You can.
Yeah.
Yeah.
So, thank you all. It's a wonderful program. Thanks, Meenakshi Madam and Prabhjit Kaur, our ISA President. Today, I'll be talking a little more about the management, actual management at the field. A few learning objectives. Already, Madam has given a wonderful introduction, and I'll go straight to the slides. 1 in 4 of us will have a stroke during our lifetime. And in India, more than 18 lakh strokes occur every year, and the numbers are increasing. And 25% of them are below 50 years of age. Every 40 seconds, a person is struck by stroke, and every 4 minutes, someone dies of it. Stroke is defined as an abrupt onset of neurological deficit that is attributable to a focal vascular cause, and with proper awareness, 80% of the strokes are preventable. There are primarily 2 major types of stroke: the ischemic stroke, which happens because of a clot or block in the blood vessel, and hemorrhagic stroke, where there is a rupture of the blood vessel and with seepage of blood. 85% of the times it is the ischemic stroke, and 15% of the times it is hemorrhagic stroke. Who can get stroke? Actually, anybody can get stroke at any time, at any age. It's just to highlight the fact birth to death. And it's an equalizing disease. The most handsome, the most powerful, the richest people are not exempted from this, and anybody can get stroke. And however, there are some conventional risk factors, as a little bit more detailed in the next talk. And the heart disease, hypertension is the #1 risk factor, high cholesterol, diabetes, old age, and smoking, alcohol, as well as obesity. The most important part of the talk is recognizing a stroke and managing it. How to recognize a stroke? With the simple acronym FAST, F-A-S-T, FAST. Remember this. F is face if there is any deviation of angle of mouth. A is arm. If there is any weakness of the arm, you can ask the person to lift up both arms and one arm drops down or it cannot be lifted up. It is arm. S is speech if there is any loss of speech or slurring of speech. T is time to take emergency call. Call the 101, get to the nearest stroke ready hospital. It is a act fast. And also be fast to recognize other symptoms too. For example, in a brainstem stroke, there will be sudden loss of balance, headache and dizziness. And for eyes, sudden blurring of eyes in one or both eyes can also be a stroke symptom. What is a TIA? It's a transient episode of neurological dysfunction, similar to the stroke symptoms that we discussed, but it will go away in minutes. It may be 5 minutes, 10 minutes, or within an hour. But it should be taken as a warning sign. High risk of getting a large stroke within 1 week. Immediately investigate and start appropriate treatment. Watch this person so that you will understand how a TIA looks like. Normal person. Getting a suddenly he goes into a deviation of angle of mouth, that is the face. And then the arm weakness with the dropping of the glass, and then he cannot speak because he's trying to call but he cannot speak. This is actually what a stroke looks like, but it can also become normal within minutes. That is called TIA. If there is a persistent symptom, it is a stroke. See, the person becomes normal. Even then, it is important to act immediately. The second step is, when you suspect stroke, always rule out stroke mimics. The most important stroke mimic that you can do at the periphery is hypoglycemia. Please check the blood sugar. If there is sugars are low, first correct them. If the deficit goes away, it is hypoglycemia. There are other causes like alcohol and infections and demyelination. So therefore, after CT scan and again do a neurological examination. There are several types of stroke, and for the most important primary level purposes, there are 3 types. One is a cardioembolic stroke, and there is a large vessel stroke where the carotids or intracranial vessels are blocked, and there are lacunar strokes. And what exactly happens in the brain when there is a stroke? This is important. There is a thrombus sitting here, and the brain supplied by this blood vessel gradually dies off. Every minute counts, because every minute 20 lakhs neurons die. And per hour, about 3.6 years the brain ages. All this is irreversible. The third concept is, you must remember, there are very good available treatments for stroke. Unlike the public opinion, people always think there is no treatment for brain stroke, as Madam was alluding, especially in rural areas. They always go to the local treatments, or Ayurvedic, or some other Siddha medicine like that. Still, till now, people think there is no treatment for stroke. However, there are many evidence-based treatments for brain stroke, just like the heart stroke. One is the most important thing, the stroke unit, which we are trying to, ICMR is trying to establish at the district level hospitals, IV thrombolysis, and in advanced cases where there is a severe stroke, we can do endovascular therapies as well as neurosurgery. I will briefly touch upon these things. The most important thing is, you must always think of the clock. It is a clock time that matters. Whenever the patient presents with stroke symptom, you must start your stop clock and then work very fast. The ASHA worker or the primary care people, whoever sees the patient, should immediately rush the patient to the nearest stroke-ready hospital, which means a hospital with a CT scan. Hopefully, every district in our country should have a CT scan and a person who can read it. Within 10 to 20 minutes, the patient should have a CT scan done, and within 30 minutes, the patient should be in the stroke unit, which is nothing but a dedicated place where there are trained nurses. And within 30 to 60 minutes, we should give the IV thrombolysis in eligible patients. This is how it should happen, ideally. And Madam was mentioning about the mobile stroke unit. We're very unfortunate that we are also having a couple of them in our country, which is there only in the West till now, where the patient can be taken into the ambulance with a suspected stroke, do a CT scan, rule out stroke mimics, and start the treatment. For example, IV thrombolytic therapy within the ambulance before the patient reaches the hospital to save time. And the other concept is, the stroke should be treated with a CT scan, after a CT scan. Only a CT scan can differentiate between a hemorrhage and infarct. If there is no hemorrhage on CT, you treat it as a ischemic stroke. This is the basic. Minimal is do a CT scan to every stroke patient. And when available, you should look at the blood vessels supplying the brain, so that which part of the brain is blocked or damaged, we will know. According to that, we can plan our treatment strategies. What about other investigations that the stroke patients need? The blood sugar is the first test that I was mentioning, not only for assessing the sugars, but also to rule out hypoglycemia, which can present like a stroke. ECG can be done, 2D echo, and carotid Doppler for the blood vessels, the carotids and the vertebral arteries which supply the brain. We should know how they are and how much block they have, and advanced vascular imaging when available. The blood investigations, routine and lipid profile and sugars can be done anywhere, and when required, troponins and thrombotic profile in specialized centers. Coming to a word about the tiers of hospitals that manage the stroke. This is an acute stroke-ready hospital, which is the first level where we can aim at to develop our district hospitals into this. This is a facility where there is a 24/7 ED physician at least available with a CT scan and neuro on-call or on telemedicine. The primary stroke center has a neurologist 24/7 and a stroke unit organized with CT scan. The third level is the comprehensive stroke centers, where all the above of the primary stroke center plus 24/7 availability of a neurologist, neurosurgical services, neurointerventionist, and advanced imaging, along with cath lab 24/7. This is the highest level of stroke care. The organized stroke unit is a simple thing which can be implemented in any district hospital and sometimes even the primary health care in the future. It is only a geographical identifiable unit wherein you keep the patients in a separate place with a trained nurses. It is the personnel, they are important. That means you are all important. the doctors and the nurses working there. This another importance of stroke unit is it is useful for all the stroke patients, irrespective of their affordability and the severity. And ISA recommends the stroke unit for all stroke patients. And what about the drugs that can be given? The IV thrombolytic therapy changed the face of stroke treatment starting from 1995-96. This drug is available all over the world, and we have used this drug extensively in India. Many of our neurology colleagues can administer this. And there is one more drug which has come into place, which can be given within 3 hours of onset. It is a bolus, and alteplase can be given within up to 4.5 hours in eligible patients. They try to lyse the clot and restore blood flow and the function of the patient. And a small simple procedure, because we want you to know about the IV thrombolysis. Whenever a patient of stroke comes, you do the CT scan to rule out hemorrhage, and inclusion-exclusion criteria. We can provide all the templates for stroke care pathways for primary levels, working with our ISA. Calculate the dose of alteplase at 0.9 milligram per kg, maximum of 90 milligrams with 10% of bolus, remaining as infusion for the next 1 hour. We have to check, most important thing is the BP. Every 15 minutes for 2 hours, for every 30 minutes for 6 hours, and every 60 minutes for 16 hours. And what about the management in the first 24 hours following IV thrombolysis? You should not puncture the patient, especially unless it is really something. Don't put on IV cannulas, catheters, the tubes, and because they can bleed. We are given a drug which to lyse the clot, and it is the tendency to bleed will be there. And avoid heparin or any other drug till 24 hours. Only after 24 hours of the IV thrombolysis, you have to start the routine treatment. Repeat CT scan can be done in 24 to 48 hours, and the rest of the treatment can start. Aspirin we will load after 24 hours and repeat CT scan, and NG tubes and other things we can start, and start the rehabilitation and manage the medical complications. Then what is the importance of BP management in these patients? If in patients who are eligible for IV thrombolysis, the BP should be less than 185/110 before you give the injection. You can use IV labetalol, which is a very simple and fast-acting drug, 10 milligrams in aliquots till a maximum of 300. And after you give the injection, IV thrombolysis, you have to maintain the BP less than 180/105 for the next 24 hours at least. This is the most important part of post-thrombolysis management. Another thing to emphasize is in patients who come late after 4.5 hours, most of our patients do come late. If those patients are fully conscious, having a hemiplegia, and they have BP up to 220/120, don't touch. This is very important. Management of BP depends on the situation. Unless they have other indication to reduce the BP, please don't reduce the BP, and especially don't never give sublingual nifedipine or injection Lasix or amlodipine 5 mg, atenolol 50 mg. People tend to give, especially these quacks in the peripheries, whenever they see a patient with stroke and high BP, they immediately give a tablet and the injection, and by the time patient comes to us, the deficit worsens. What about the general management of stroke patients? ABC, supplemental oxygen if SpO2 is less than 95%. Manage the body temperature, as temperature can worsen the stroke. Bedside swallow test is very simple. We can teach the nurses. You have to give a bolus of liquid to swallow and see whether they are choking, they are cough, and there is any wet voice. If there is any of these indications of dysphagia, you don't give anything orally, put a ice tube. Management of high sugar, stop the oral drugs and give Actrapid, short-acting sliding scale. IV fluids, anti-edema measures as required. General care of the patient with nutrition and physiotherapy, change of position, all these things will start within the 24 to 48 hours. What about, these are the basic treatment. What about the patients who have a major stroke, where there is a big vessel which is blocked? Simple IV drugs, thrombolytic drugs cannot manage this big clot. In these patients, there are availability of advanced stroke treatments, which is called the endovascular. What is the concept of endovascular? In IV thrombolysis, we give injection in the vein, but in endovascular, we take a catheter, a small plastic tube all the way up to the brain. See, look at from here, from the thigh to the brain. all the way up here, and we reach the clot. This is the clot which is sitting there in the middle cerebral artery, for example. And then we give either an injection, or we can give a mechanical devices like a stent retriever or a penumbra device to suck out or retrieve the clot and restore the flow. This is a very fantastic treatment. If it is successful, the patient will start recovering on the table. Just have a look at this one, where you go all the way to the brain, to the vessel, and put in a tube and a balloon, and look at that. We suck the clot out all the way from the brain into the carotid artery, through the aorta, through the femoral, and all the way out. I will show you one of our case which we have done. This is a gentleman who came with a complete basilar occlusion, and there are no collaterals. See, look at this 100% basilar stroke, which is if left non-treated, they will have 100% mortality. No patient will survive. We have gone up with this solitaire, which you have seen in the animation, and then brought out this clot, and the patient is, the blood flow is restored. This is the blood flow restored, and patient became very much normal. What about the role of neurosurgery? There is something called endarterectomy. When your carotid arteries get blocked more than 70%, we can open that blood vessel, the vascular surgeons can do, and then scoop out this cholesterol mark there sitting, and then suture up the vessel. Very simple, but very effective in these patients. Stenting also can be done in different other treatment for this. And there is something called decompressive craniactomy, where there is a big, huge infarct sitting there in the brain. To give the space for the edematous brain, you remove the flap of the skull. This is called decompressive craniactomy, which is also very effective treatment. In case of cerebellar strokes, you can also do decompressive craniactomy to save the patient's life as well as function. Now, coming to the what about after acute treatment, what is it? The secondary stroke, which will be elaborated again by my next speaker, is very important. Once a patient gets stroke, even if he recovers, he should always be followed lifelong to give treatments and drugs and follow up to prevent a second stroke or MI or any other vascular problem. I would like to again go through all these in a simplified way for the doctors right at the primary level. The field workers like ASHA should identify and refer suspected cases of stroke to nearest stroke-ready hospital. Suspect stroke when there are fast or BFAST symptoms. If the patient becomes normal, treat it as a TIA, but still the history, hypertension, smoking, diabetes, do CT scan, sugar, and ECG at least. And if the CT scan has no hemorrhage, give aspirin and atorvastatin and refer to higher center for further evaluation immediately. If there are persistent symptoms, do CT scan immediately. This is a stroke. The previous is a TIA. Consider IV thrombolysis if within 4.5 hours in consultation with ED physician or neurologist. And PHC level, a patient comes to the PHC hospital with a sudden focal neurological deficit, apply fast and be fast again, check bedside sugar to rule out hypoglycemia, get them to nearest stroke-ready hospital. If it is the stroke-ready hospital already, perform an urgent CT scan. If window period less than 4.5 hours, CT scan rules out hemorrhage, consider IV thrombolysis. If still there is a major deficit persisting and patient is still semi-conscious, refer them to higher center for advanced stroke imaging and neurointervention. And what about at district level or advanced? If it's more serious, more other patients, any sudden focal neurological deficit with altered consciousness, severe headache, vomitings, where you suspect severe stroke or a major thing. If the CT scan showing ICH, it can first decrease the BP with IV labetalol and maintain with oral drugs and supportive care. And if there is no hemorrhage, with hemorrhage, check and maintain ABC, airway, breathing, circulation, oxygen supplementation, and RBS monitoring. Injection of mannitol intravenous at 150 ml, 100 ml, you can give over 30 minutes. And always remember, please give on anti-emetic. Most of the patients have aspiration by the time they come to the next hospital. Please give either Pednar or Marjofer in IV to avoid aspiration. If there is any history of seizures, IV anticonvulsant and position, left lateral position, nil orally, don't give anything in the mouth. Refer to higher center when indicated. And the rest of the general management of stroke, along with IV thrombolysis, you have to manage your sugars and fever, start rehabilitation, And in patients who present late, beyond the thrombolysis window, CT scan to rule out hemorrhage and start on aspirin 325 statin followed by 150, atorvastatin 80, insulin for diabetes and supportive care. At discharge, please add antihypertensives to all ischemic stroke patients in addition to aspirin and statin, even if the BP is within the normal range. Educate the caregiver about medication and diabetes monitoring and teach them home rehabilitation, which is found to be very useful in one of our studies done by Professor Dr. Jairaj, our ISA president. Ensure follow-up and continuous medication for secondary prophylaxis. Again, this is very much doable at your level. So always remember that stroke is a medical emergency. Recognize it fast, get treatment fast. In this workflow, fast treatment, call ambulance, ED evaluation, get CT scan, get into the serious stroke unit, or even before that, you can give the thrombolysis within the CT scan if eligible, and then manage post-care. And we would like to have your cooperation in this to join the fight against stroke with Indian Stroke Association. Thank you.
Thank you, Dr. Vijaya, for that wonderful talk. And now we'll move to the next speaker, Dr. Ganesh Kumar. And then after his talk, we'll take the question and answer. So please post your questions in Q&A or chat so we can answer your questions. So Dr. Ganesh Kumar, this is yours.
Thank you, Dr. Arvind. Thank you, India Stroke Association. So I will be discussing to all of you on prevention of the stroke from the more of primary prevention angle. So my name is Dr. Ganesh Kumar. I work as a scientist in ICMR National Institute of Epidemiology, Chennai, and represent India Hypertension Control Initiative team. So these are the 10 important the stroke prevention proven strategies, which includes control of the high blood pressure, exercising 5 times a week, and reducing high cholesterol level, abstaining totally from smoking, eat healthy, balanced diet, reducing the intake of alcohol, and perfectly having a strict control on diabetes, identifying and treat the atrial fibrillation, if any, maintain ideal weight and waist-hip ratio, and reduce the stress. So this have a lot of literature evidence have been proven that these are the 10 important proven stroke prevention strategies. So India Hypertension Control Initiative, it is a multi-partner joint collaborative initiative, which is based on a package called the WHO HOTS package, mainly to strengthen the hypertension treatment component of the national program NPCBCS. This was launched in November 2017, and we have partners from Ministry of Health and Family Welfare, Government of India, Cscs, WHO India, and we do have state governments, and we have a technical partner also, RTSL. We have so far enrolling the patients across nearly 100 districts, which is spread across 19 states. And these are all the states that what you are seeing there. And there are certain essential steps of hypertension and diabetes control at health facilities level. And I'll just be walking through that. The one what you're seeing in the right side is a hypertension protocol, which we adopt in this India Hypertension Control Initiative. This is a simple treatment protocol, stepwise protocol. And if the patient is not controlled in one step, they are escalated to the other step, which has a specific medication dosage and as well as the schedule. And the second important part of the important step for an hypertension and diabetes control program is uninterrupted drug supply. So the drugs should not be allowed to be stock out, especially at the treating facility. So there should be a frequent supply of drug, and the patient should not go away without any kind of drugs. That's the most important key aspect of hypertension and as well as the diabetes control. And we need to dispense for an hypertension patient of minimally 30 days of drugs, and the drug delivery should be nearer to the patient's home. So we have also found that when we bring the drug delivery closer to the patient's house, like the health and wellness center, the control rate have enormously increased. So bringing the hypertension, which is the most important risk factor for the stroke, and bringing the drugs for the hypertension control closer to the homes of the patients will really improve the hypertension and as well as the diabetes control, which will also do the prevention of stroke. The third important essential step is team-based care in the facility. As you all know that in any healthcare facility, any disease cannot be treated by a single person. It's a kind of a team effort. It's by doctors, nurses, pharmacists, at the field level, say like at the health and wellness center level, there are frontline workers, we have A&M, we have ASHAs, and along with that, there are other ancillary staff who are also working along with the health system, who should work as a team in bringing the control of hypertension and diabetes. And we need to involve all cadre of the staff. It's not just the hypertension and diabetes control is only pertaining to, say, doctors and as well as the nurses. It's also to the multiple cadre of the staffs. Fourth important thing is patient-centered care, which means that the patients should feel like they are not getting spin around inside the facility to get a simple care. So we need to reduce the turnaround time when a patient is coming inside the facility to get a care related to hypertension and diabetes, so that the continuum of care do exist. And this will also improve the patients to come back for a follow-up, and it will improve that. And we also need to consider the patient when we are administering the therapies. For example, we need to administer once daily treatment regimen. This will improve the compliance among the drug, compliance of taking drugs among the patients, so that the patients will be in continuum of care. Finally is the patient information system. So when I say patient information system, then we need to understand that hypertension and diabetes patients has to come regularly to the health facility. So if 100 patients are getting treated in a health facility, and they have to come 12 times in a year, which amounts to 1,200 visits and 1,200 blood pressure recordings. So we need to know what are the previous blood pressure recordings of a patient, and as well as the previous blood sugar recordings of a patient, diabetes patient, so that we need to titrate the doses, titrate the drugs as per the protocol. In order to do that, we need to have a strong information system, so that we need to know as a doctor, as a nurse, as a team, healthcare team, that whether the patient is actually getting better, whether his hypertension and diabetes are getting controlled after initiating this therapy, and also whether the patient is coming regularly for follow-up. So for that, we need to have a very strong patient information system. This is another important strategy which we adopt in India Hypertension Control Initiative. And this will also bring us that most important indicator, that control. So once we treat, say like for example, some 1,000 patients in a health facility who have been registered as hypertensive or diabetes patient, then we need to know out of 1,000, how many were brought under control after initiation of this therapy. And for this also, this particular indicator is the most important indicator, which is called control rate. For this, we need to have a very strong information system. So these are the 5 important strategies which we adopt in India Hypertension Control Initiative. And apart from that, through the frontline workers, through the doctors, nurses, and pharmacists, we educate the patients on lifestyle changes. These are very, very important. Drugs are not just enough to control high blood pressure. Lifestyle changes are as a most important supplementation for that. So the most important lifestyle changes is like increasing the consumption of fruits and vegetables, like 4 to 5 servings every day. Reduce the salt 1 teaspoon, less than 1 teaspoon per day, and avoid alcohol and tobacco completely, so that their hypertension, diabetes are getting controlled better. So we commemorate this 29th October as a World Stroke Day with the most important theme as Prevent Stroke, Protect Your Brain. And most important SOCO here is we need to know your number. So at the age when you are crossing more than 55, your risk increases. When you cross your blood pressure more than 130/80, your risk increases. The same way, your LDL, your fasting blood sugar, your BMI, we need to know these numbers. These are all like kind of the most important numbers that every individual should know about it. So what I'm requesting here is that all you doctors should know this is the number that you need to educate the patients, that they should be aware that these are all the numbers which are called risk numbers. And as a part of this particular World Stroke Day, this theme, Protect Your Brain, And we need to educate these patients on these kind of important indicators so that they will also be under care. So the most important take-home message that which I am trying to tell you here is that primary prevention is the most important key strategy for stroke prevention. We need to screen. The most important risk factor for stroke is hypertension. So by screening all 30 years and above, those who are visiting to a health facility for any type of illness, or the attenders also, we need to screen their blood pressure. And we need to manage it very efficiently. And we should also know and check their modifiable risk factors, especially blood sugar, other comorbidities, if they are suffering from diabetes, their waist circumference, their physical activity. And we need to continuously educate the public about managing these risk factors and following appropriate lifestyle. So let's join the fight against a stroke. And one important take-home message I just want to say here is that 1 in 4 survivors of a stroke will have another stroke. So we need to continuously follow up if the patient had a history of stroke, and we need to regularly check their blood pressure and also educate and encourage them to do regular checkups and continuously make them to follow the treatment, continue their treatment to prevent the second stroke, especially treatment of hypertension, diabetes, and keeping themselves under, say, like as per the opinion of the treating neurologist, aspirin and statins continuously. So along with this Indian Stroke Association, let's join the fight against the stroke. Thank you, everyone.
Thank you, Dr. Ganesh, for your wonderful lucid talk. And now moving on to the, we asked everyone to post the question and answer. So to keep the ball rolling, we'll take the questions from the Q&A. I thank you both the speakers, and it's a wonderful talk that and the importance of hypertension and prevention of stroke and the treatment on time, and beautifully depicted with the videos by Dr. Vijaya about the thrombectomy and the treatment. I'll go to the first question by Dr. Spurti Magdam. There are many studies conducted on pranayama and yoga to control hypertension. Don't you think it should be added in the preventive modules? I would like to take this question to our president, Indian Stroke Association, Dr. Jairaj, if you can, for stroke also, right? Rather than for stroke, hypertension will.
Yeah, for stroke, there are some small scale studies, but we don't have large trial with good number of patients. So at this point in time, as like what we say is physical activity, there could be some impact on the autonomic nervous system, thereby BP can come down, heart rate can come down. So definitely there is some role, but we need to have more evidence for that.
Dr. Jairaj yesterday also mentioned about the Ayurveda and other alternative medicines. He has mentioned about the evidence-based medicine, and today also he emphasized on the pranayama and yoga for the control and hypertension. I think I will take the question to Dr. Prabdeep, if you can give your words on it. And I think she is not there. Dr. Ganesh, can you please?
Yes, sure. So especially related to these lifestyle modification practices, like rather than mentioning pranayama and yoga, it's most important is lifestyle modification practices. It has the most important supplemental effect, but however, drug intake is proven to be the most important strategy for control of hypertension. And these lifestyle modification practices improves and sticks the patients to stick to a single drug therapy and continues to get the better control of it.
Yeah, I think I agree with Dr. Ganesh on this. And we should use all these therapy as an add-on and not a replacement for antihypertensives. I think that's the message. If you look at IHCI training manual, we have very clearly written, we recommend all the lifestyle changes, whether it is yoga, whether it is diet and all of that, but it's not a replacement, because the point is like how many millimeter reduction you can get. And that's relatively small with any of the lifestyle this thing. So if you use it as an add-on, it's very good. But if you don't use drugs, then BP is unlikely to remain under control.
So So we go to the next question. Dr. Vijay, it's for you. The kindly enlighten us by Dr. Muthurama. Kindly enlightens us about recent development in pediatric ischemic stroke.
Yeah, as I was mentioning, actually, you must think of stroke in any age. I would like to tell the first thing is prevent birth hypoxia during delivery, safe delivery, and being conscious about that it can cause brain damage is the most important preventable stroke in children starting at birth. A safe mother and delivery. The second thing is in childhood, there may be infections or even trauma, minor trauma can precipitate stroke. We must be, if the patient has any minimal weakness also, we should not ignore and take special attention to that and treat. Secondary causes, all these are. There are primary cause of stroke in children is a little bit rare. Adolescents, it can start. Prothrombotic states are genetic diseases where the person has some problem in the blood that will make them clot. If there is any adolescents having this stroke, you must investigate for the causes like protein C, protein S deficiency, which are treatable again, like APLA in young ladies who present with abortions and headaches, and if they have a stroke symptom, you can treat. For children proper, secondary causes are more important. And one important newer thing is the Moya-Moya syndrome, which can happen in India also. And that's a specialized problem which has to be dealt with the neurologists with the advanced brain imaging. And there are some treatments for these neurosurgical revascularization procedures. So the concept is to suspect stroke in childhood and look for the underlying etiology. Depending on the etiology, you have to have treatment.
So next question is, what are the risk factor of stroke that we can change? Dr. Jairaj, if you can pitch in for.
I think the both had mentioned about the risk factor, the modified risk factors. Number one is hypertension. So 80% of the strokes are preventable. The risk factors are, the 10 risk factors for stroke. They are all modifiable, like diabetes, high cholesterol, detecting atrial fibrillation, preventing heart attacks, and smoking, alcohol, drug addiction, obesity. So there are all these are all preventable by lifestyle factors.
So thank you, Dr. Jairaj. The next question we already mentioned yesterday also answered that question, clinical differentiation between cerebral infarct and hemorrhage. So don't go on the symptoms. It can be very deceptive. So CT scan is equivalent to ECG. Always if you want to differentiate, that has been very made clear yesterday and today also for all the physicians, that you have to, if you want to diagnose MI, you do a ECG, right? Which it's an inferior wall or it's an anterior wall. So see, similar, if you want to rule out a hemorrhage or an infarct as a clot, you have to do a CT scan. So now for Dr. Vijaya, can you?
Dr. Arvind,
yeah.
There is another question in the chat box related to this from one of the community medicine doctors from AIMS, Delhi. My question, why can't thrombolytics be administered in stroke patients without CT scan? Many patients coming to PHCs cannot go to district hospital fast, and hence early administration of medicines to mitigate the residual effects of stroke would help.
So that question, it goes very clear that see, in heart you have only the blood, there is a clot, but in brain there are two types of stroke, right? 85% are ischemic stroke and 15 to 20% are the stroke which are hemorrhagic. So as a doctor, you know that you cannot harm a patient, right? You have to know what is the diagnosis. You cannot presume only on the clinical basis. So you can do the first aid, you can do the primary treatment to that patient, you can manage the sugars. If there are definite clinical symptoms and sign of stroke, you can do those first aid like sugar, manage the airway, and immediately ship the patient to a center where the CT scan is available. So that is why more and more districts are being provided with the CT scan. Without CT scan treating a stroke, then it is dangerous that you will harm the patient if the hemorrhage is there. So it is not possible. So you have to do the CT scan. So the next question was same. Another question was there. This was by Dr. Sandeep Das. And the another question was, Dr. Vijaya, what are some future treatment possibilities about the stroke?
Yeah, as I was mentioning, the future treatments are basically endovascular. Most of them are managing everything through the within the vessels, just like in cardiac diseases. We can go, for example, for carotid artery, we can either do a endarterectomy, or a patient's not eligible for endarterectomy, we can do a stenting, especially when your patient has a TIA and a 70-80% stenosis of the carotid. We can do stenting and manage them with double antiplatelets. For intracranial aneurysms, for a cause of cerebral hemorrhage, one of the causes is cerebral aneurysms. They can be easily managed now endovascularly with go and coil, with several techniques, which can make a person normal for the rest of his life. So there is so much advances in the endovascular region. And neurosurgery also is pitching in with timely, prompt. That's the timing. Everything is about stroke management, is about time. You have to see the patient and decide at what time, what treatment fits the patient without doing harm. Always think about the risk-benefit ratio in a particular patient.
Thank you, Dr. Vijaya. And the future possibilities for stroke rehabilitation, I would like Dr. Jaraj to pitch in.
Yeah, so first of all, our patients should get an early evaluation for rehabilitation and also some of the basic rehabilitation. So that itself is a big struggle because we don't have enough rehab centers or hospitals with some rehab facilities. So as a result, many of them get therapy at home with trained or untrained physiotherapists, and so that itself is a big challenge. Future, of course, there are many technologies that are evolving. Tele-stroke rehabilitation is one. Then that is the physiotherapist can supervise the therapy by video or using a smartphone. Then second is robotic rehabilitation. Then there are, for every disability, there are specific techniques, technology-based, and that can be used, like game-based rehabilitation, virtual rehabilitation. So these are all evolving based on technologies.
Thank you, Dr. Jaraj. And the next, Dr. Krishna Priya, talking about the hypoglycemia, blood sugar, of what level one will go in for the risk of stroke. Dr. Salil, you want to answer that question? Salil is the executive member for Indian Stroke Association.
Can you hear me?
Thank you for joining. Yeah, we are able to hear you. Nah.
At what level?
Yeah,
maybe you have to repeat the question.
We missed. Hypoglycemia blood sugar level, what level one will go, that is less than 60, is very important. We should know, we should consider hypoglycemia. Dr. Salil, we are not able to hear you. I think there is some problem in the mic. So that is very important about the hypoglycemia. They are one of the very important stroke mimic whenever the patient comes to. So we added that into the vitals, the pulse, blood pressure, SpO2, temperature, and blood sugar, which is very important in diagnosing the mimic for acute stroke. Now coming to the next question, where do we find clinical preventive service guidelines on similar lines of USP STF for Indian settings? Are there any links that could refer? Right now, it is all scattered. So, Dr. Jaraj.
Yeah, this is the guidelines, basically. So preventive guidelines, we don't have exclusive stroke prevention guidelines from India, but Indian Stroke Association has published guidelines for management of stroke, and also through the national NCD program, stroke guidelines have been published where prevention also is given a lot of importance, and that guidelines is being revised now. So there are resources available where you can get all this in one place.
Thank you very much. That was very important. You can go to the ISA website to download those guidelines. They are there on that. So in continuation to the same rehab clinic, Dr. Jaraj, there is a question from Dr. Sandeep Das. Are there any plans of making rehab clinic in PSCs, CSCs in the future?
Yeah, so yes, in the NCT program, there is, as part of palliative care, there is a community, I would say, integration of care, but still we are in the discussion phase. In one of few forums, we have raised this, and there is, I would say, a plan, but it has not been, the concept has not evolved. And because community health workers, there is data that if you train them at the community healthcare level, primary healthcare level, we can deliver some basic rehabilitation. It is possible, but it needs to be done. Yeah.
Thank you. Dr. Vijay?
Can I?
Yes, Dr. Meenakshi, please go ahead. I was not...
Very interesting question.
Yes.
And I think Dr. Pandian and Dr. Arvind, you will agree with me. This is one research question which has actually been posed to us, and we should take up studies in PHCs whether stroke rehabilitation is possible over there. National program guidelines may be saying that, but we have to really show that it can work over there. So we will be very happy if the physicians, if the doctors sitting in the PSCs, they are willing to participate in these kind of trials. So we can work towards that. We can really work towards that.
Thank you very much, Dr. Meenakshi. That was very important part which you have mentioned about, and ICMR can take the initiative for that part, and the physicians who are ready. Thank you very much. That is very important, because if you see, not, as you say, only 10% are taking the hypertensive medication, and ICMR has taken the initiative for hypertension initiative to make it double. 20, at least 20 should take their, and they should know their blood pressure. Similarly, this is a challenge for the stroke neurologist and all the neurologists, that not many percentage of patients reach to the hospital for thrombolysis and the treatment, and they reach late, but they also have deserved, and that is the most important aspect of the stroke treatment, to do, as Dr. Jaraj mentioned, early rehabilitation and early physical exercise, the goal directed for those patients of stroke. So moving to the next question, Dr. Vijaya, can mannitol be given to every patient without going for CT scan to decrease ICT?
The mannitol, as you rightly said, is to decrease the raised ICP. But what is the way you suspect a raised ICP? If the patient is unconscious or very drowsy and incontinent, only those patients have raised ICP, not a fully conscious alert patient with a hemiplegia. So in case you don't have a CT scan immediately and the patient comes to you in an unconscious state or a drowsy state, you can give, if the BP is not very low, you can administer mannitol. 100 to 150 ml stat over 20 minutes.
Thank you. Thank you very much for that answer. Now, another question is from Dr. Muthurama. Laborious cost of thrombolysis kindly substantiate this propaganda for resource-constrained country like ours. Dr. Muthu, I'll start this answer and you'll get more from our experts, that all the institutes like AIMS started that, and subsequently all the institute, even at Gujarat where I work at the civil hospital as associate professor, the thrombolytic drug is free, right? So we should not always talk about the cost. If you see the cost of the stroke, if they are not thrombolized, and when they have to do the physiotherapy, and the cost of the economy, which the family has to suffer, is seen by WHO, WSO across world, and Dr. Jaraj will give his expert comment about it. So it is not only the cost of the treatment of thrombolysis, it is about the cost if you don't do the treatment of acute stroke, and how much the cost. It was much way higher, and seen in Canada, Australia, and US, and even in India. So Dr. Jaraj, you can...
Yeah, so I see the treatment that we are talking about is intravenous thrombolysis. If it is given in 90 minutes time, the number needed to treat is about 3.4, and within 3 hours, it's about 8, 9, and then within 4.5 hours, it's about 13. And if you look at endovascular treatment, the number needed to treat is 2.7. There is no intervention in the world where you have that level of NNT. So these are all very powerful treatment, efficacious, and it is cost saving, in long term. Just imagine somebody is completely dependent and did not arrives to a hospital in time, but it does not get these two therapies, if they are eligible, then they are left with lifelong disability. Of course, mild to moderate strokes will improve with rehabilitation, but severe strokes, maximum 10-15% they improve. So they will be disabled for life. So that itself, if you look at the direct cost and indirect cost, it's a huge economic burden on the patients and the relatives.
Thank you. Thank you. And I totally agree with that. And all the specialists here will agree on that part. And now going to the next question, Dr. Vijay, you already mentioned about the pediatric stroke. Pediatric population are not including in the thrombolysis in stroke guidelines. Kindly advocate for including pediatric population too. Just for your information, that pediatric stroke are being treated with thrombolysis and thrombectomy. Dr. Vijay will further emphasize that.
Yes. So the guidelines say from 18 years, they are the guidelines, but out of the box, in fact, it is suggested, recommended in an eligible person. In children also, we do give IV thrombolysis according to the weight, and then we can also do the endovascular thrombectomies.
Yeah, thank you very much. So Dr. Meenakshi has mentioned a request to all of you to send implementation research questions, which you feel should be taken up and will stroke care at PhD level. Definitely all will agree to that part, and we'll also request that ISA can be of any help will be there for that. So going to the next question, because another 5 minutes, we're going to wind up this session. 3:15 is the deadline. So I'll take 1 or 2 more questions more. Does the brain heal after the stroke? It is by Dr. Riju Dubey. Does the brain heal after the stroke, and how much time it should be taken? Dr. Vijay is smiling, so I think she wants to answer it.
The brain has a great plasticity, neuroplasticity. As we were discussing yesterday, brain does heal and continues to heal uninterrupted. Don't think that recovery stops at 6 months or 1 year. It will improve throughout life. That has been scientifically proven. Therefore, always think it will improve and do all the supportive measures, especially good rehabilitation, in addition to moral and family support, and reinstating their occupational therapy and all the things. It should be a multi-pronged, multidisciplinary approach to recover the patient. Brain does heal. Continuously it is.
Thank you. So the next question is by Dr. Manchika Chalvi. Most of the patient may be with diabetes, CAD, and hypertension. Is it possible neurostenting or neurointervention?
Yes, it is. Neurointervention is decided on several factors. The most important is the type of stroke. As I was mentioning, if there is a large vessel stroke, then that is what is indicated.
So the question is, I think, until unless the patient is not having stroke, you cannot go for a neurointervention. That is very clear. Not every diabetic, CAD, or hypertensive patient should be done as an intervention. And you are talking about the asymptomatic carotid stenosis, Dr. Chalvi, then it is a totally different ball game, where you have to see that the study says that if it is greater than 70% also, the other further studies to be done for such intervention. So until unless stroke is not there, you are not going for the intervention. Now going to the next part, I think I'll answer this question. Does a smoker of several years still benefit from quitting smoking? Definitely. Smoking stopped any point of time heals your whole body. That includes your brain. So quit smoking now. If anyone on any platform should quit smoking, definitely it helps the world. So
within 2 years of quitting smoking, your risk comes to baseline. Within 2 years of quitting smoking. So
thank you, Dr. Vijay. Thank you. And I think here I come with all the questions being done. almost. And I think,
Dr. Arvind, there is one question on implementation research.
yes.
Dr. Preetham Mahajan, where do we send these concepts on implementation research? Dr. Meenakshi, you can.
Yeah, Dr. Meenakshi, can you please answer that question? I'm not able to see, Dr.
Right, then the last one.
Last one. Sorry. Last one.
Yeah.
Oh, a little bit.
Yeah, down here.
Down.
So it is.
I think you can send it to. Can you hear us? I think you can send it to me, to Dr. Pandian, and to both of us you can send. We would really love to see what are the questions which are coming from the PHCs. So when we formulate questions, they are really different from the ones, from the problems which you are facing, whether it's hypertension or stroke. So I think it's a good idea that this forum actually gave me an idea that we should have more of that sort, so that we can know that what the ground level really wants us to do. And if that is done, I'm very sure that we'll be able to do many activities for control and prevention of both stroke and hypertension. So that was the idea. Dr. Pandin, I think both of us, we can, if you want, we can share our email IDs with you.
Sure.
Dr.
I'm just
Arvind can share. You can
Dr.
share.
Jairaj Pandian just did, has sent his email ID. So I think, thank you very much. Now from here, we'll just close the session by some wise words from our extreme panelists. So I would like to start from the senior scientist and ICMR non-communicable disease, Dr. Meenakshi Sharma, to give some final words for this session.
I think it was a very lovely session. So that kind of things we hardly see happening in India. But when we go to the PHC level, when we meet the physicians, the nurses, and the frontline workers, then I think we mean business actually in a way. We really want something to happen over there. So these webinars have opened our eyes to the expectations which our PHCs are having, the difficulties which they are having. And we will make efforts from the research point of view that whatever can be solved, whatever questions can be solved by us, we'll try to find answers with help, with your help only. Thank you very much for such an interactive session. Thank you. Thank you, everyone.
Thank you, Dr. Meenakshi. Thank you for your kind and wise words. And it was definitely a wonderful collaboration. Dr. Prabdeep.
Yeah, thank you very much. I think this was an excellent webinar, and there were very good questions. And I think we haven't been able to fully address all the questions, but I think this is a learning for us. And we will try to, maybe we'll try to address some of these questions as a FAQ and circulate again. I think most of your emails might be there with us. And I agree with I think many doctors have mentioned that, you know, they would like more clarity on what they can do in primary care. There more clarity of guidelines, and myself and Dr. Meenakshi were also discussing this yesterday. So actually it's really opened our eyes as to what the felt need is on the ground. And I think we will come back to you with more information and try to make it easier for you to do stroke management and referral. But I only want to emphasize again the importance of hypertension control, because this is a really serious issue for us. Despite making drugs available, only 30 to 40% patients are achieving control. So we have really, you know, a lot of scope to improve in that. And we also need to improve coverage. We are right now, even in the better performing district, only about treating 20 to 25% of the patients of all hypertensives. So we should be treating more. And of course, I think very important that ensuring follow-up of stroke patients. So this is something you all can do at the peripheral level, keeping a line list with ASHA. Line list, patient can be called, asking them to come back for follow-up for their medication and making sure they continue the medication long-term to prevent another stroke or a heart attack. Thank you, and thanks for the opportunity. And we look forward to this being a continuous discussion. Thank you.
Thank you, Dr. Prabdeep. Thank you. Agreed with that hypertensive initiative which you told and collaborating with stroke. And I would like to call upon our President of Indian Stroke Association, Dr. Cscs, to closing remarks.
Yeah, thank you. So it was a great interaction, and the questions were very interesting, very practical, and we also received a lot of new ideas, particularly looking at the grassroots level problem and barriers in implementing the evidence-based treatments. That is where the implementation research comes in, and particularly rehabilitation at community level and post-stroke care at community level. These are some of the important needs, unmet needs, I would say. We have some models, but do they really work at the community level? This is where the technology and medicine can join together and apply it and do an implementation research. And but overall, my comment is stroke is preventable and treatable. Early recognition is very important. That is where you all can play a major role, and also in prevention of stroke, targeting on hypertension, diabetes, and other risk factors. Thank you.
Thank you very much to all. And as a moderator and Secretary of Indian Stroke Association, I would again thank all the wonderful speakers, Dr. P. Vijaya, Dr. Ganesh Kumar, and our EC member, Dr. Salil Uppal, Dr. Meenakshi Sharma, Dr. Pradeep, and Dr. Jairaj, and ICMR, NIE, and India Hypertension Control Initiative to arrange this webinar. And we are very grateful to have a wonderful interaction for the World Stroke Day 2021. And we look forward for further in the next year, we have more and more interaction, and we all believe that it will happen in future. Thank you to all. Thank you very much.
Thank you very much.
Thank you.
May I request all the panelists to just be remain and
Okay.
I want to take a snapshot.
Okay, Dr. Pradeep, can you please video on your video, please? So, Dr. Ganesh want to take a picture.
So, Dr. Pradeep, are you there? Okay. So I'll just say 1, 2, 3. Please smile. Right. 1, 2, 3. Done.
Okay.
Thank you, Dr. Ganesh. It was really very nice to close it this way. Thank you, and looking forward to see you again. Yeah.
Thank you very much.
Thank you.
I hope